All right. So now I will review JAK inhibitors for alopecia areata. Again, earlier today, Dr. Abram and I were talking about hair and how, it used to be that there was sort of an obligatory talk about hair loss at a meeting because hair belongs to dermatology, and so we had to talk about it. But I think JAK inhibitors are part of JAK inhibitors for alopecia areata in particular have sort of kind of made hair sort of more interesting as a pursuit in dermatology, because for the first time in the last few years we've been able to do something really dramatic, which I think has given us all a little bit of excitement about treating hair in general, as I think all of these really amazing talks have highlighted. So these are my disclosures. Many of these are relevant to this talk. And this, again, I think is the excitement about alopecia areata and JAK inhibitors. For the first time in the history of this disease, we are able to reliably do this. It's not that somebody didn't do this in the past, but we can now reliably tell those people at the top that there is a very good chance that we're going to make them look like those images at the bottom. And so what are the clinical trials? There are now a whole bunch, a couple of topicals and some oral trials. There are many more in progress, but these are the ones for which we have a lot of data. And we're only going to review the data for one topical JAK inhibitor clinical trial, and that's ruxolitinib 1.5% cream. This was actually one of the very first clinical trials of a JAK inhibitor in severe alopecia areata, and really important, it didn't work, right? We always want to see the bars be very high, and here literally one patient grew hair over 24 weeks of treatment. And so the idea is that topical JAK inhibitors are ineffective for the treatment of at least severe alopecia areata, and this is supported by other data. So now baricitinib, phase 3 clinical trial, showing at 2 doses of this medicine, 2 milligrams and 4 milligrams, 2 milligrams in blue, 4 milligrams in red, that over the course of a year, 20 to 40% of patients have complete or near complete scalp hair regrowth. A SALT score less than or equal to 20 means 20% or less scalp hair loss. All of these patients started with 50 to 100% scalp hair loss. And so a really dramatic effect to be able to tell 4 out of 10 patients that they are likely to regrow their hair over a year of treatment. And this, of course, changed, I think, dermatology forever. A year and a half ago, the approval of baricitinib for adults. Now, ritlecitinib. Now, this was or is another medicine that hopefully we've all heard about. This clinical trial was in adults and adolescents, right? And we know that alopecia areata is common in children. And so here, again, looking at the achievement of complete or near complete scalp hair regrowth over 48 weeks of treatment with different doses. Now, this was huge because we learned 2 things. One, that it works, but 2, right, it is said, and I think, right, all of us in residency, and I think actually most review chapters and book chapters on alopecia areata say that development of this disease in childhood portends a poor prognosis. It's always been a little bit unclear to me what poor prognosis means, if that just means that they usually tend to severe disease or that they don't regrow their hair. But really importantly, we've learned from this clinical trial that adolescents respond just as well as adults to treatment. And again, kind of a seminal event in dermatology 7 months ago, the approval of ritlecitinib in adults and adolescents. So now we have a therapy approved for ages 12 and up with severe alopecia areata. So now we have 2 therapies. What are we going to do to optimize treatment, right? So both of these therapies, ritlecitinib and baricitinib, both achieve regrowth in about 40% of patients. Well, 40% is not 60%, it's not 100%, and so what are we going to do better? So we're going to look at data from these clinical trials. The first is data from the baricitinib clinical trial, the 4 milligram dose. The dotted line are patients who started the clinical trial with 95 to 100% scalp hair loss. So think essentially like the folks who I think we've historically called alopecia totalis or alopecia universalis. And then up above, patients who started with 50 to 94% scalp hair loss at baseline. And look, we literally almost double the proportion of patients who achieve regrowth by treating them before they lose all of their hair. And so this is really, really important, right? We want to treat patients before they lose all their hair if we have an opportunity. So the patient who's sitting in your office and they have 70% loss and they're wondering whether, kind of hemming and hawing, not sure if they should do treatment, this is useful, right? Because you don't have to tell them to do it, but you can say, by the way, therapy works much better before you lose all of your hair. So what else affects treatment? Well, the duration of current episode. This is not the duration of disease, right? If I'm 40 years old and I had my first spot when I was 10, but I regrew my hair up until I was 30, and then I lost all of my hair, the duration of current episode, I'm 40 years old, the duration of current episode of severe disease is 10 years. It doesn't matter that I've had disease for 30 years. It matters that I've had severe disease for 10. And what do we see, again, from the baricitinib clinical trials? The folks, the bottom 2 curves have greater than 3 years duration of current episode of severe disease. The folks in the top lines have less than 3 years duration of current episode of severe loss. And what happens again? Literally, we almost double the effectiveness of treatment by treating patients in the first 3 years versus after the first 3 years. And so you can only imagine, right, if you take patients in the first few years and who have not lost their hair, it may be that we're achieving efficacy of 60, 70, 80%. It's really dramatic. And so this data helps us think about and helps us talk to patients. So again, we want to treat early and before there's complete loss. So, right, everybody asks, what if I do nothing? Will my hair grow back on its own? We now know. So this is again what every book chapter says to be true, right? That alopecia areata is waxing and waning. Even if you do nothing, your hair will grow back. I mean, I don't know that, actually, I believe that that's true for the majority of people, but for sure, I think that when that is written, it's written for sure about the person on the left-hand image with a spot or 2. I don't know that most patients with ophiacis pattern really have waxing and waning disease. I think it's very often persistent. And then I think once it becomes kind of moderate, once you're in that 30% or more range, I think it tends to be persistent, but we could debate that. But the question is, what about these folks? The folks who have severe loss, right? 50%, 80%, 100% scalp hair loss. So remember, every chapter says it waxes and wanes, but right, those 2 images represent, I'm certain, 20% at least of people with disease, and maybe even 40 or 50% of people with disease. And so how do we answer the question? What happens if they do nothing? Well, we know from clinical trials, right? And this clinical trial result is repeated in the ritlecitinib clinical trials, is repeated in a clinical trial of a medicine called duruxolitinib. The folks who do nothing, meaning the folks who take placebo, do not grow hair over 24 to 36 weeks of observation. And so we can now tell the patient who asks, what if I do nothing? We can say, oh, nothing will happen. You will continue to not have hair. Or maybe you have a 2% chance. So we've learned a lot about the disease, right? So all of those chapters, all those book chapters need to be rewritten. And we need to say it's often a disease that is waxing and waning, but it is also a disease that persists. So when can treatment be stopped? Again, I think we ask ourselves this question. It's really funny because we don't ask this question of ourselves with our psoriasis patients, right? As good as our psoriasis biologics are, right? We now had 13 of them in our toolbox, and not one of them fixes psoriasis permanently. As good as our treatments are of atopic dermatitis, not one of them leads to a durable remission off therapy, but we continue to ask ourselves, well, when can we stop treatment of our alopecia areata patients? Well, we now have an answer. Again, from the baricitinib clinical trials. So on the far left of this graph, you take patients who in the first 52 weeks of treatment regrew their hair, and then you see what happens when you continue to dose them at the dose that they regrew hair with at the top. You see that over another year of observation, the vast majority of them continue to have their hair. And what happens when you withdraw treatment? They lose their hair. 80 to 90% of patients over the course of a year lose their hair. What's cool about that is that 10 to 20% of patients keep their hair. I would say that that's kind of amazing. That number doesn't exist in psoriasis. It doesn't exist in atopic dermatitis, but it's still not the majority of patients. So I would just say stopping treatment in general is a bad idea if the patient wants to maintain their hair. And we're going to see in the next slide how to taper or how to think about tapering. Again, not what I think, but what happened in the clinical trial of, again, baricitinib. So on the far left, we take people who regrew their hair at the 4 milligram dose, and then over the next year, half of patients continue the same dose, so 4 milligrams, and you see a year later, 90% of them still have their hair. And what happened to the folks who abruptly changed from 4 milligrams to 2 milligrams at week 52, we see that almost half of them lose their hair over the next year. Some of them lose their hair at week 4, a tiny number more lose their hair at week 8, but we see over the next year that the slope of the line continues to trend down. And so I would say that we can learn from this that in general, try not to go from 4 to 2 quickly. I would say maybe never go from 4 to 2, but that's personal. I would say that if you're going to try to taper the dose, do it very slowly. Maybe go every other day 4, alternating with every other day 2, and take those dose steps every, say, 4 months to give time for the disease to manifest in case you went too far. And so, kind of putting it all together, after regrowth, I would say just continue the dose that the patient grew hair with, but if you want to, or if the patient wants to, just make small changes. Again, try not to go from 4 to 2, right? It took a long time to grow the hair. You take somebody who has no hair, a year later they have all their hair, maybe it's down to their shoulders, and then you take a 50-50 chance that over the next year they're gonna lose it again. It's just not, it's not fun for patients. And it's not fun when they're calling your office urgently. screaming, crying, that they're losing their hair. And so go slowly and make small changes over long periods of time. And these are the conclusions. JAK inhibitors have really changed the way we think about this disease. They've really made it possible to treat disease. We now have an approved drug, ritlecitinib, down to age 12, hugely important. And so we should all be embracing this and taking care of these patients and making their lives better. So thank you all so much. And now I'll turn it over to Dr. Avram to wrap up the session with hair transplantation.